Welcome back to The Explainer. Today, we're diving straight into a series of real, high-yield exam scenarios to unlock the actual why behind those correct surgical answers. We aren't just going to memorize facts today, we're going to look closely at the underlying physiology and physics. So whether you're prepping for the boards or you just want to sharpen up your clinical reasoning in the OR, these safety pearls are absolute gold. All right, let's take a quick look at our clinical roadmap. We're covering pacemakers and electrosurgery, harmonic scalpel tech, smart bandage complications, and we'll wrap up with lithotomy nerve safety. Let's get right into it. Challenge number 1, pacemakers and electrosurgery. Picture this. You're in the OR and your patient has a pacemaker. You're gearing up for a lipoma excision on their right thigh. So where exactly should that dispersive diathermy pad go to minimize interference with the cardiac pacemaker? Are we thinking A, below the right calf, B, below the left buttock, C, below the left calf, D, below the left ankle, or E, below the right ankle? Take a second and lock in your guess. And it's A, below the right calf. But why? Well, it's all about the physics. We want the electrical circuit to be as short as physically possible to minimize the risk of stray current crossing the myocardium. You place the pad under the ipsilateral, or same side, right calf to keep that current vector entirely localized within that lower extremity. Now, why the calf and not the ankle? Surface area. The calf has a much larger surface area, which drops tissue resistance and significantly cuts down on heat generation. This is a perfect example of how we map the electrical circuit in the body. You've got to orient the active electrode and the pad so the pathway runs perpendicular to and completely away from the pacemaker's leads. Imagine if you place the pad on the opposite side, like the left leg. You'd basically be forcing that current to travel right across the pelvis and abdomen, heading straight toward the torso. That's a huge risk for electromagnetic interference, or EMI, with the pacemaker. Always isolate that current vector from the torso. Oh, and a quick pro tip. Always use bipolar diathermy whenever it's feasible, or stick to really brief sporadic bursts if monopolar is your only option. Moving right along to Challenge 2, harmonic scalpel tech. All right, let's switch gears from electrical circuits to physics for a second. Listen to the specific trigger words here. What type of waves are used in a harmonic scalpel while cutting tissues? Is it A, radiofrequency ablation, B, ultrasonic waves, C, ultraviolet rays, D, X-rays, or E, none of the above? If you went with B, ultrasonic waves, you nailed it. See, the harmonic scalpel doesn't actually rely on electricity to cut. Instead, it uses high-frequency ultrasonic waves. It literally vibrates the blade tip at a mind-blowing 20,000 to 50,000 hertz. That crazy fast mechanical movement slices through the tissue, while at the exact same time sealing adjacent blood vessels through protein denaturation and mechanical pressure. It provides fantastic hemostasis. Let's put these two head-to-head. Unlike traditional electrosurgery, which uses electrical current and intense heat, the harmonical scalpel runs on mechanical energy. That means you get a massive thermal advantage, significantly lower lateral thermal spread, which equals far less collateral tissue injury. Plus, it generates minimal surgical smoke, which keeps your visibility crystal clear in deep surgical fields. But it's not perfect. It's definitely slower than standard electrosurgery, and it only coagulates while it cuts. You can't just spot coagulate an actively bleeding vessel out of context like you can with a traditional bovie. Okay, let's tackle Challenge 3, S-mark bandage complications. This scenario covers a super routine but potentially risky pre-surgical step: limb exsanguination prior to tourniquet use. What is the most common injury caused by S-mark bandage application to a limb? Think about what's physically getting squished under all that tight rubber wrap. Is it A, vascular, B, muscular, C, nerve, D, bone, or E, ligamental? Take a guess. The answer is C, nerve injury. When you wrap an S-mark bandage improperly or just leave it on way too long, that tightly coiled rubber generates totally unpredictable extreme pressures, sometimes over 1,000 millimeters of mercury. That brute force mechanical compression crushes the vas nervorum, leading to local ischemia. The specific pathology we're dealing with here is called neuropraxia. Basically, it's a temporary roadblock for nerve signals without actually tearing the nerve architecture apart, meaning it usually heals up within about 6 months. Now, what's really fascinating here is that not all nerves take the hit equally. Because of how compression physics work, the large diameter, heavily myelinated nerve fibers are actually way more vulnerable than the small, unmyelinated ones. In the upper limb, the radial nerve is your usual suspect. Down in the lower limb, you really have to watch out for the sciatic nerve, and especially its common peroneal branch, right where it wraps around the fibular head. And that brings us to our final hurdle, Challenge 4, lithotomy nerve safety. We're going deep into spatial awareness and biomechanics in the OR right now. This is one of those notoriously tricky, multivariable board questions. Which of the following is correct regarding the lithotomy position? We've got options A, B, and C all arguing there's less chances of damage to either the femoral, obturator, or sciatic nerve when the hip is flexed past 90 degrees. D suggests less chances of damage to the sciatic nerve with more than 30 degrees of hip abduction, and E claims both legs shouldn't be elevated at once. Read those specific angle triggers carefully. Did you catch it? The correct answer is B. There's actually a lower chance of damaging the obturator nerve with greater than 90-degree hip flexion. Let's think about the mechanics of this. When you hyperflex that hip past 90 degrees, you're putting a ton of stretch on the sciatic nerve, and you're actively pinching the femoral nerve right beneath the inguinal ligament. But that exact same movement actually relieves tension along the specific anatomical pathway of the obturator nerve, completely dropping the risk of attraction neuropraxia. Pretty wild, right? Let's actually put this all together into a master safety matrix. This right here is pure high-yield gold. For the sciatic and common peroneal nerves, hyperflexion past 90 degrees is absolutely your enemy, along with direct compression against the metal stirrup at the fibular head. The fix? Avoid extreme flexion and use plenty of padding on that fibular neck. For the femoral nerve, hyperflexion pinches it against the inguinal ligament, so keep flexion moderate. The saphenous nerve gets squished against the medial tibial condyle, so be sure to pad all those inner bony prominences. And finally, the obturator nerve is stretched by excessive hip abduction past 30 degrees, so you've got to limit abduction to a natural, moderate range. Before we wrap, I want to hammer home this overarching positioning rule. Both legs must always be raised and lowered simultaneously by two operators. Why? Well, this final pearl isn't just about crossing out option E on a multiple choice test. It's about actively preventing massive acute torsional stress on your patient's lumbar spine and dodging sudden, dangerous hemodynamic shifts. It's a real-world, non-negotiable absolute.
Okay, put yourself in the hot seat. Take a look at the vignette and try to find the scientifically accurate statement. Now, wound dressings might seem pretty basic, but boards absolutely love to test the specific physiological interactions between the dressing material and the wound exudate.
Here are your options. A. Duoderm is permeable to fluids. B. Tegasorb for third-degree burns. C. Alginates for light exudates. D. Colstosopt for partial thickness burns. Or E. Acroderm absorbs moderate to heavy exudates. Take a second to mentally lock in your choice. Remember, we're hunting for the one statement that is definitively true.
If you went with D, excellent job. Caltostat is an alginate dressing. That means it's derived from natural seaweed and is super rich in calcium salts. The magic happens when this dressing actually touches the wound exudate. There's this fascinating calcium to sodium ion exchange, turning the dressing into a hydrophilic, hemostatic gel. It's literally perfect for partial thickness burns and split thickness skin graft donor sites that have moderate to heavy drainage.
Now what's really interesting here is the stark contrast between those other options. Look at hydrocolloids like Duoderm. They are completely impermeable to fluids and bacteria. They essentially trap moisture inside for shallow wounds. Adhesive films like Tegaderm, on the other hand, are waterproof but actually oxygen permeable, which lets the wound breathe. But here's the kicker. Neither of these should ever be used on third-degree, full-thickness burns or deep puncture wounds. Doing that just traps bacteria and promotes anaerobic infections, which we definitely don't want.